bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today we're going to shine a light on weight bias and stigma and ask the question, is a focus on the scales helpful or harmful to the health of our children? And the topic of childhood obesity is always a topic of interest to the CAFC community, often described as an epidemic. It's one of those problems where the solution often lies in working across sectors and settings, healthcare, education, engaging communities, et cetera, et cetera. So always remains very complex and very persistent in Canada. So it's a great opportunity to welcome an expert in the field to come and tell us a little bit more about the topic, and hopefully there's something we can take away from this. And it's actually my pleasure to welcome Dr. Sara Kirk back to a CAFC podium, not our webinar podium, but she did present at our annual conference in Halifax last year. Dr. Kirk is a professor of health promotion and the scientific director of the Healthy Populations Institute at Dalhousie University in Halifax, Nova Scotia. She also has cross appointments to the IWK Health Centre and Mount St. Vincent University, and her program of research explores how we can create supportive environments for chronic disease prevention. So it's my pleasure to hand the virtual podium over to Dr. Sara Kirk. Over to you.
Thank you very much. Thanks for the great introduction. And also just wanted to mention that I do have an affiliated appointment at the IWK Health Centre as well. So I kind of feel like I'm speaking to, or hopefully speaking to people who share the same sort of passions as I do in terms of child and youth health. Without further ado, I'm going to first of all start off with this on this webinar with getting you to reflect on your own behaviours. This is obviously quite challenging because I can't see any of you, but I want you to think about how your own behaviours might play into the way that we frame issues of weight with children and with adults. So thinking about your own physical activity behaviours, and are you actually being physically active enough for health benefits? So that would be around 30 minutes of physical activity 5 or more times per week. Are you eating at least 5 servings of fruit and vegetables each day, which we would use as a marker for healthy eating? Are you getting enough sleep? And the amount of sleep that we all need is around about 7 to 9 hours, depending on, there's certain amounts of personal kind of characteristics within that. But really, we all should be trying to get at least 7 hours of sleep a night. And do you limit the amount of screen time that you have? I'm sure many of you know that the recommendations for children and youth are less than 2 hours of screen time a day. And really, we shouldn't be having that much more than that. So I think that's something also to be thinking about. So reflect on your own behaviours for now, and then we're going to come back to that shortly. But today I'm going to focus on 3 challenges in shining a light on weight bias and stigma. I'm going to focus on how obesity is often framed as an individual problem that can be solved by eating less and moving more, and how this kind of approach that is seen very much in this sort of simplistic framing actually leads to an accompanying narrative of blame and shame that then results in weight bias and stigma. So I'll talk a little bit about how that happens. And finally, I'm going to talk about the challenge that this narrative remains unchallenged because it is something that we often don't talk to the people who are experiencing these kind of narratives around weight bias. And what that then means is it undermines the health of everyone. But I am a glass half full kind of person, and I also like to really think about the three solutions that we have to this issue. The first solution is that we need to address those key drivers, and the drivers that I'm really going to focus on today are blame, shame, and misinformation, and how that then impacts how we address weight within our kind of current system. I'm going to talk about some of the work we've been doing at Dalhousie and in Halifax around putting the people affected at the centre of discussions, and also about how we've been changing the narrative around we understand weight and health, both within and outside of health settings. Okay, so let's first of all start with that point about addressing the key drivers. And as I say, the main ones that we're talking about here, the blame, shame, and misinformation. And the first thing around the blame and shame and misinformation is this the belief that weight is controllable. And the second thing that I'm going to talk about is the myths of personal responsibility and willpower. And then I'm going to kind of lead on to talking about weight bias and stigma and how they kind of play into this as well. Okay, and the first thing, I'm going to ask a question, and again, this is always very difficult when we're in a sort of webinar situation, but I'm going to pose the question to you about how easy is it to control weight. So think about your own weight and think about how easy it is, because many people actually think that weight is entirely controllable, but I would argue that it's not as easy as people think. First of all, this is a diagram that comes from some work that was done in the UK several years ago now. But if you think about this little kind of model sort of shows energy balance and really shows the sort of things that are needed in order to maintain energy balance. And when we're talking about energy balance, we're talking about the number of calories that people consume in the food that they eat, balanced with the number of calories that they burn out through physical activity. What you can see in this model, and this is just the kind of the central engine, if you like, of energy balance, is you can see that it's very much controlled by the importance of our physical needs. If you sort of go to the little grey box in the middle of the diagram where it talks about we have an importance of physical need, and that then drives us to acquire energy, and the amount of effort to do that is actually quite significant. So think back to our kind of, caveman days, if you like, and recognizing how if we were hungry, we would have actually, walked many, many miles to acquire energy or acquire food. And then that then feeds back into this sort of like loop around the level of available energy. So once we've got our energy, that then sort of, then helps us to sort of store energy as fat, and then that then feeds back into that loop around the importance of physical need, but that's not a very strong relationship. So what we find is that it's not easy to control weight because our bodies are very, very much sort of bound to this evolutionary mechanism whereby the need for energy or food drives physical activity. So we'll go and collect food and we'll find food in whatever format we need it in, but the feedback loop isn't that strong. And so if we have all these other things sort of happen as well, so we have a tendency to preserve energy when food is not available, that then feeds into that loop. But we can also control or try and control our behaviours around eating, which then might interfere with that feedback loop, and that's also something that we need to be aware of. And the key thing here is that the evolutionary mechanism where we actually go and seek out food, the reverse mechanism is actually much, much weaker. So think about it. You have, you're hungry, you need to find some food, and you seek that food. Nowadays, food is available very, very readily. You could eat something, but you don't get that same desire to go running a marathon or trying to sort of be physically active afterwards. So one of the things that we're, trying to sort of explain here is that it's not easy to control weight. We can control our behaviours, but we cannot control our weight to that degree. And actually, when we look at all the potential contributors to obesity, they're quite substantial outside the person. So again, we often see weight as we think of weight as controllable, that it's something under the control of the individual, so inside the person. But as you can see from this figure, which comes from the Obesity Society from the US, you can see that there are many things that actually are contributing to either increased intake, intake or energy expenditure or expenditure, but we don't know, or decreased expenditure inside the person. And there's an awful lot of things that are actually found outside the person. So just to give you an example, you can see on the left hand side inside the box we have things like disordered eating can contribute to increased intake. We can see that things like age-related changes or chronic inflammation or genetic and epigenetic factors can actually have some impact on things like intake or expenditure, or we don't know. And then on the decreased expenditure, things like pain sensitivity, physical disabilities can have an impact on that. But then when we look on the outside of the person, so things that are outside of an individual's control, there's a lot more things. The market economy, food advertising, the amount of food that we consume outside of the home all contribute to increased intake. Things like infection, weight gain, family conflict, social networks, all those kind of things might influence intake or expenditure. And then things like having a consistent temperature, so things like air conditioning and heating are all sort of things that actually do impact our expenditure that, again, we don't have a great deal of control on necessarily. So that brings me to the next point, which is around these myths of personal responsibility and weight and willpower. So and back to those habits that you talked about, that I asked you to think about previously. So when I ask you, are you physically active? Are you eating healthily, like 5 or more servings of fruit and vegetables, or even managing to sort of follow Canada's food guide? Are you reducing your screen time, getting enough sleep? Well, when we ask that question of Canadians, and this has been asked in things like the Canadian Community Health Survey, around half of Canadian adults will report being physically active or moderately active during their leisure time. Around half of the adults will report consuming 5 or more servings of fruits and vegetables. But when we start to get down to actually doing all of those behaviours, so those 4 behaviours, if we consider those to be things that we should all be doing to be healthy, then we're getting down to around about 5% of people will actually adhere to all 4 behaviours. And so that really kind of makes us think about, okay, well, why are we not able to do those things, especially I'm assuming that that people who are attending this webinar are all people who are actually very, work in a health environment. So if we, the very people who should be modelling these behaviours, aren't able to do it, then what does that say to the rest of the population? And so this is important, and it's particularly important for the topic of weight bias and stigma, because virtually the entire population is not achieving evidence-based health behaviour recommendations. So we know, every one of us knows what we should be doing, but there are many things that are actually stopping us from doing that. And the other thing that's really important here is that we're all exposed to those risk factors for chronic disease, regardless of our weight status. Often we think about weight as being the kind of predictor. So if somebody has a higher body weight, then they are unhealthy. Whereas actually we're all exposed to that environment. We all are, potentially unhealthy. So we have to then ask the question, is this a moral failing of the majority of the population? Or is it that healthy behaviour is actually abnormal behaviour? And that diagram on the right-hand side of this slide shows us, we're almost pushing a boulder uphill when you think about all the things that impact our health. Poverty, inadequate food and nutrition, lack of education, unemployment, poor housing, and environmental health hazards are all kind of weighing us down, and we're having to push that boulder uphill. And it's very, very hard to see the whole population sort of changing. It's very hard to sort of push that boulder uphill, or very hard to sort of change your behaviour in the face of all those pressures. And here's that central energy balance. The slide a few previously where I was talking about energy balance, you can see that right in the middle of this diagram. But around this diagram, you see all the things that impact our body weight that are quite overwhelming, and this, it's even hard to read this diagram because there's so many relationships going on there. But essentially, this is what's called a sort of a causal loop map, or causal map of the relationships that impact energy balance, and you can see it's very, very complex. And if I show you this, this is a sort of another kind of view of the map with the overlaying some of the things, the agents that actually can be enablers or barriers to change. And you can see, though, on the left-hand side of this diagram, there's macroeconomic drivers. So, that's essentially the consumer culture that we live in that impact our ability to maintain a healthy body weight. There's food production and supply. It has a big impact. The way that our built environment is structured, the nature of work, technology, education, media, and early life experiences are all important here. And I think what's really important to note here as well is that healthcare and treatment options are actually a very small part of that big picture around what causes obesity. And I think this is what I wanted to really emphasize, is that when we're talking about obesity as an individual problem, we're ignoring all these other things that have actually led to this, led us down the path of higher rates of obesity among our population, both adults and children. But that narrative of personal responsibility, that myth of personal responsibility and willpower, basically plays out like this. So, we say people need to eat less and move more to lose weight. That's something we often hear, and that comes out in adverts, and you think about magazines where, they're often focusing on weight, how to lose weight, the diet sort of options that tend to be sort of promoted. And so, that's what we hear. People need to eat less and move more to lose weight. And then that means, or leads to, if people eat less and move more, then they will lose weight. That simplistic sort of view. And if people don't lose weight, then they must lack willpower or be non-compliant. Yet, I've sort of shown you already that there are, less than 5% of us can actually maintain the 4 behaviours that really we should be doing in order to be healthy. Does that mean that we're all non-compliant? But really what's coming out here is that those kind of narratives that we hear are very much pointing the finger of blame at the individual and saying it's their fault. If somebody gains weight, it's their fault. And those blaming narratives cause a lot of harm. So this diagram sort of again shows you how that actually happens. And this is adapted from work from the Canadian Obesity Network, which actually has a priority around addressing weight bias and stigma. So we have those negative attitudes and views about obesity, and people living with obesity are called, that's bias. And what that leads to is the development of stigma, which is the labeling or stereotyping, attributing damaged identities, so seeing people as failing if they're unable to maintain a healthy body weight. That's deeply rooted in society. And that can then lead to things like verbal, physical, relational abuse that can be subtle and overt, that discrimination that happens. And we know from research evidence that people with obesity are discriminated against. They're discriminated about in the health system, they're discriminated against in terms of their academic achievement, in terms of housing, in terms of getting hired for jobs as well, and that stigma and bias are very, very widely held. The general population holds those beliefs. The healthcare professionals, a lot of work being done in healthcare professionals that also hold the beliefs of weight bias and stigma, and again teachers also, and that those rates of weight bias and stigma are actually equivalent to those of sexism and racism, if not actually almost higher, because we've done a huge amount in terms of addressing sexism and racism over recent years, and this is research from 2009. And so just to give you another illustration, as I put up 2 silhouettes here, you have the one on the left is a higher body weight, and the one on the right is of a lower body weight. And you will have automatically already, most likely, attributed characteristics to each of these silhouettes. And if I put up some characteristics for you, so here are 6 descriptors that we could use for these people. So one of these silhouettes is a marathon runner, one is organised, one consumes a lot of junk food, one likes canoeing, one's a good leader, and one's socially awkward. You would likely have attributed the positive characteristics, so a marathon runner who's organised, who's good at canoeing and a good leader, to the silhouette on the right, and junk food and socially awkward to the silhouette on the left, even though actually it could be the other way around. But that's because we hold these beliefs, and these beliefs is what we call implicit bias. So even though we don't know anything about these silhouettes or the people that they represent, we would attribute negative characteristics to people with a higher body weight. It's something that we do, that we're almost not aware that we're doing it. And that leads to this sort of like dialogue and this feeling of us and them. So, I have this image here that is from a chap called John Holcroft, who had this in a magazine actually in the UK, and this is how people feel when this is a picture of a woman having a cup of coffee and feeling those knives coming towards her around, well, if anybody's eating in public who's of a higher body weight, then we blame them and we shame them and we think that they're being greedy or lazy, or all these sort of things come out. But what we also know, and there's a lot of evidence now coming out, that shaming and blaming people does not facilitate behavior change. In fact, it has the opposite effect. It actually makes people more likely to overeat, and that it then increases morbidity, mortality, and social inequities. The evidence there is very, very strong. So in fact, we have the opposite effect. However, that doesn't mean that we don't still use those tactics, and that they're very, very widely used, particularly in the healthcare setting. So weight bias, in my opinion, is a social justice issue. It's something that we really need to be looking at in terms of the social determinants of health, and actually sort of recognizing that it's not right to blame people for something that actually, as I've shown in the earlier pictures, is really influenced by a lot of factors outside of that individual. So that takes me on to the next solution to the problem, which is really putting people affected at the centre of discussions. And we've done a lot of work in my research group. So just putting on the slide some work that was done among some colleagues of mine at Dalhousie University and the IWK, looking at the management of obesity within the Nova Scotia health system. Now, this was looking at adults, and so I'm kind of using this as an example just to sort of show you some of the work that we have been doing to kind of really address weight bias. I do have some paediatric data to share with you as well in a minute. But what we did in this research is we looked at weight management from multiple perspectives, from the perspective of individuals living with obesity seeking support, from the perspective of healthcare providers, and also from the system level. And from the system, we're really talking about the sort of people who are setting the budgets within a health organisation, people who are sort of deciding what services to offer or not within the healthcare system. And we have a subsequent paper just recently published, literally this last month, where we were actually looking at this from sort of the mental health perspective as well. So I've just put those up in case anybody's interested in sort of reading more about the work that we've done. But what we did is when we spoke to the this is mainly the data from the two groups that we interviewed in terms of the healthcare providers and the individuals living with obesity. And what people said to us, that these dialogues of condemnation, that there's such a stigma there that is reinforced. But when I enter the health system, the first place I expect to talk candidly about my issue, I hear the blame. Well, if you eat right and exercise, you'll lose weight. It's as simple as that. It's a simple thing. That's what I get. It's so simple. So again, you're hearing that narrative that I previously mentioned around, well, you are in control, you should sort of be able to lose weight. And then there's another person there. There aren't supports for people that are trying to lose weight. And sometimes I don't feel like the doctors are really on board. They think it's a food issue and that's it. So I don't feel like the supports are there for those people. And we heard a lot of that from our participants, very much a sort of a challenging dialogue that came from both sides. And what was really interesting in our findings was that the healthcare providers, mentioned that they had blamed people, but they also blamed themselves, and they blamed themselves for not being able to have anything much to support people with. And so what we did with this, we had such rich data that we actually combined it to make a script. So it's sort of like it's a short 14-minute dramatic kind of presentation that, as you can see from the picture here, we have what looks like a doctor, but really could be any healthcare provider, and a patient. And they're at this point in the drama, they're he's actually weighing the patient, and she's sort of talking about her feelings about being weighed within this sort of setting. And so what these two characters are, so two character play, what they talk about is they talk about their sort of, the external kind of conversation that people would have with each other, and then their internal dialogue is actually sort of spoken to the audience. So we put these interviews into this sort of like dramatic presentation, and it really highlights those spoken and unspoken tensions that our participants described about weight management within the system as it's currently constructed. And then we actually incorporated that into a 3-hour interprofessional workshop where we get healthcare students and healthcare professionals actually have also been involved in this, to rewrite that script. So they watch the drama, they do a bit of brainstorming, and then they work together in interprofessional groups to rewrite that script. So it's a more positive interaction and a more positive consultation. We've had around 700 healthcare providers and students going through the training so far, and we have had a really great response from people as well. So in terms of is doing this, the rewriting the script effective? Well, yeah, it's actually helped people understand the topic of weight bias and stigma. So a score out of 5, we normally get around 4.5. That they found it very helpful for reflecting on weight biases and stereotypes, and helpful for use in future practice as well. And one of the things that we now do pre and post test is actually a measure called the anti-fat attitudes test, which is very much looking at do attitudes towards people with a weight issue actually decrease, and we see a significant reduction pre and post workshop. So this is a validated tool that's been used widely in the literature, and we do see those reductions, which is good to see. And in terms of how people have found that work, so what participants say is that it really educated me on the topic of overweight in the health setting. I've always felt that it is a sensitive topic, and that someone who is overweight should not be judged, as it's not just behavioural but biological as well. But now I have a reason to defend this. So people it was actually empowering healthcare providers, and we already know from our other work, just even having the opportunity to speak about their experiences, as they did in our original study, our participants also felt very empowered because they were actually being listened to and actually felt that they had a role to play in addressing this issue. Another participant said, I like how it incorporated different health professions, and it made me critically think about the stigma behind weight. A third one talked about the rewriting the narrative, and felt that was a very effective way to sort of look at that hidden script behind the scenes and understand what was fully going on. So that was really encouraging as well. Okay, so I've covered so far the sort of the challenges that the narrative around weight bias and stigma, or the narratives around how obesity is managed, then impacts weight bias and stigma. And now I'm going to talk a little bit around actually changing the narrative and how do we actually address this moving forward. And so this is where I sort of bring in some of the work that we've done from the paediatric perspective. And so some colleagues of mine and myself worked and developed a sort of did a sort of a review of what successful childhood obesity management might look like in primary care in Canada. And this is a sort of quite an interesting sort of approach that we took, because we have clinical practice guidelines in Canada. The clinical practice guidelines were actually released in 2006. So they're, over 10 years old now. And so we wanted to kind of sort of think, okay, well, if we were managing obesity within their primary care setting, what might that look like, and how likely is it that somebody would actually achieve that within the sort of, that kind of, if they followed those guidelines. So what we did, this really kind of takes it from 7 steps that are required in order for somebody to achieve weight, to achieve either behaviour change or weight loss. And we were fairly loose in how we define this, because it's actually fairly loosely defined in the literature as well. And the first step is that, for somebody to actually get care and help for a weight issue, they need to have a primary care provider. And that is not universal. So we do still have people who do not have a regular primary care provider. They then have to go to that primary care provider, and again, that then sort of decreases the odds. They then have to have that primary care provider actually measure the child's BMI, or assess the child by visually looking at the child to say that child is of a higher body weight. That then has to lead to some action being taken. So step 4 is recognizing that the child perhaps needs some support. Then they have to have a discussion about that, and then they can either go down 2 pathways. So that could be either to initiate an off-space weight management program within their primary care setting, or to refer a child to a specialist weight management program. And the 7th step then is that that the child and family adhere to whichever approach that's taken, and that then they have that weight loss or behaviour change as their outcome. And what you can see here is that the odds decrease as the child goes through this pathway, to the point where at the end, to achieve that outcome, we're looking at less than 1% of children actually being able to sort of follow those 7 steps all the way through to the outcome that we're looking for. And that the biggest bottleneck is actually the lack of a pediatric weight management program specifically for the child. You can see that those are the 2 boxes that are highlighted in red on this slide. There's such little capacity to do that within our current system. And here is some of the data from the Canadian Obesity Network, which is looking at what clinics actually exist across Canada for pediatric weight management. And you can see that there's this, and this is self-reported, so there may be things on here that I'm not aware of in some of the provinces that weren't actually recorded in this, but you can see that there's actually sort of poor coverage across the country. And I'm in obviously the Maritimes, where we have no specialised paediatric management clinic. What we have on versus other places, Alberta and Ontario, and obviously they are more heavily populated anyway, and BC, where they do have some things. But that I think is, again, very interesting sort of to see that is actually holding back our ability to manage issues related to weight in children. And that has huge implications in terms of, again, we have, a third of children in Canada, 1 in 3 kids will have overweight or obesity, yet we have nothing, very, very little to offer them. And yet the interesting thing is that, we don't have capacity to manage obesity according to those best practice guidelines. So how can we connect people to something? So again, the idea is that, if we were actually to connect people to the solutions that are available, but if we don't have anything, then that's an issue. And that's why, this is a picture of an iceberg, because, we're really only sort of, scraping the surface and, looking at the tip of the iceberg. The interesting thing, though, is that when outcomes are much better when there is a specialist service. So when we have access to, children have access to something, then we do have a much better outcomes. And it really highlights to me that, we need to manage obesity and we need to prevent obesity. And, a lot of the focus of my work now is around preventing obesity, because it's almost like, if we only focus on obesity, then we're missing all those other people. Again, going back to those, your own behaviours and how easy it is for you to sort of like manage your own behaviours. We're all struggling on that front. And it's not just about obesity. So this, again, is another thing I think is really important in the way that we talk about weight. We talk about obesity a lot. I've done this a lot in my earlier work, is, obesity is a problem. We need to do something about it. But actually, think about it. The whole of us, the whole of society are not eating healthy. We're all sitting around too much. We're not being physically active enough. We're not getting enough sleep. We're not looking after our mental health, and all those other things. So we're not healthy. And we don't see investment in upstream actions to address the social determinants of health. What that means is we still put an awful lot of money into the acute care system, the healthcare system that involves treatment rather than prevention. Across Canada, it's roughly 95% of funding will go into the acute care system, and only 5% really goes into the, and this is a ballpark figure, but goes into the prevention. And we actually have a culture that conflicts with the behaviours that are needed to reduce the burden of ill health in Canada. So we're only focusing on obesity. We're missing all those other things that are influencing our health. And these are data from some work we did on women of child-rearing age. These are actually women in the Nova Scotia at-need perinatal database so these are people who are women who are pregnant, who, when they have their baby, the baby gets kind of captured in the database, and it's a really rich source of information. And for all the women that we have in this database, and there's around 110,000 in the sample that we analyse for this particular presentation. This is pre-pregnancy weight, but you can see there, and I think this is what we're looking at in terms of the shift in distribution of weight. So when we're concerned about, we are concerned about the doubling of overweight and obesity among our population, because we've seen that in adults and we've seen it increasing in children. But also look here, we're also seeing reductions in the number of people who are underweight, reductions in the number of people who are within that normal weight category as well. So that's the distribution of weight is moving to the right, so towards heavier. That's everybody's exposed to that. So again, just reinforcing the point that we need to be aware that the exposure, if you like, is on all of us, even though only sort of like, a third to a half of people, still a large number, are actually at the sort of at the stage where we need to maybe be concerned about their weight. There are other factors going on here as well. Physical activity or physical inactivity is a major component, and this is kind of really fueled by this shrinking footprint that children have. So this is data from the UK, where you can see that, looking across the generations, you can see great-grandfather was allowed to walk 6 miles, grandfather could walk a mile on his own, mother able to sort of walk half a mile, the son only allowed to walk to the end of his street. So we've seen this kind of like shift in the patterns of physical activity in our kids, not active as much as they were, not walking or cycling to school in the way that they used to. This ironical situation where, we've actually engineered physical activity out of our children's days, and now we have to find a way of putting it back in. And often when we put it back into our kids' days, that's actually at a time that's actually then displacing another behaviour. So after school, the after school period is like, in some of our work that we've done, again in Halifax, we found that when we were looking at parents of junior high school aged children, talked about being overscheduled in ways that limited options for healthy meal preparation. So, and again, I'm sure there's many of you on the call who have kids who are, or know of kids who are participating in after-school sports. I actually took this photograph while I was sitting on the sidelines with one of the mums, who you can see there. She had actually had to go to Wendy's drive-through in order to get food for her and her son on the way to the football match, or the soccer match, sorry, my English coming through there. And ironically, you say we're seeing this, this sacrificing of healthy eating in order to sort of accommodate that after school period, and parents actually privileging one behaviour over the other. So actually choosing to, thinking that physical activity was more important behaviour to do, rather than thinking that maybe both of them are. Other work that we've done is looked at the inaffordability of healthy food. We've done some work there's been a lot of work in Nova Scotia because we have among the highest rates of food insecurity across Canada. And so what we find, and this is another thing I think that really plays into that sort of narrative around weight, children who are experiencing food insecurity, be it marginal, moderate or severe, are likely to have significantly higher body weights, BMIs. They're less likely to be meeting the recommendations in Canada's food guide for things like fruits and vegetables and milk products. And they're also more likely to have mental health challenges, so reporting relationship mood or externalizing problems, which is essentially things like acting out behaviours, so sort of disruptive behaviours. And the photograph here, again, was taken from a colleague of mine who was sort of showing the sort of, the placement of, Coke and Pepsi for 2-litre bottles of Coke or Pepsi for $4 versus 2 litres of milk for $3.19. And, this kind of, contradiction. You think, well, okay, that somebody can't be food insecure if they have a higher BMI because they've obviously had food, but this is the problem. The types of foods that are cheap are often the ones that are heavily processed and actually not particularly nutritious. So, if you're starving or hungry, what are you going to do? You're going to eat foods that fill you up rather than foods that perhaps won't do that. And culture really matters, and so I've just kind of thrown in this particular situation that arose in Nova Scotia a few years ago, which is when the government sort of sent around a reminder to parents actually it wasn't to parents, it was to the school boards and schools around the school food and nutrition policy that we have in schools in Nova Scotia, and I think again are in other provinces across Canada. And this particular parent took exception to what she considered to be a nanny state, sort of, it's my right to give my children cake, is how she sort of described it. And I kind of got involved in it. Ended up being a bit of a Twitter battle, if you like, around what we call then kind of like #CakeGate. And again, here's some correspondence that was I took from a screenshot on the web, where she's talking about, it's my right to sell cake, and we're fundraising. And so again, that sort of unhealthy environment that we then, often sort of puts us in a very difficult position, as the way that we make money a lot of the time is on unhealthy foods. And I often sort of put this up as well. This is actually a screenshot that was posted by Ricky Gervais, who's a comedian who sort of set up The Office, the Office show, who tweeted this, because of the irony again of, on the one side we have Nova Scotia's at the forefront of an obesity trend, on the other side we have a picture that says pancakes, and so again sort of really sort of showing that culture where we have on the one hand unhealthy foods and unhealthy behaviours that actually sort of, we often don't see them kind of how that then is playing out in the problems that we're now seeing in terms of obesity. So I'm going to sort of kind of try and bring us back now, because I'm conscious that we're getting to the end of the time, and I'd really like to sort of have some time for questions. So one of the things that we do in our research is called a socio-ecological approach, which really tries to sort of understand how all these influences actually then impact on our behaviour. So health is not just healthcare. We need to recognise that it sort of extends beyond that, and that therefore improving health is not just the responsibility of the health system, although I think we as people within a health system need to be the sort of champions, if you like, to this. That we need to think about the role of social determinants of health and support sustainable change, and encouraging that to happen multi-sectorally, across different organisations, as was mentioned at the beginning. And one of the things that, again, if I was to look at sort of like behaviours like physical activity and screen time and unhealthy eating and healthy eating, if we want to really make a difference, we need to be doing all of those things. If we only focus on, individual physical activity, then we're going to have a smaller impact. But if we look at this across these multiple spheres of influence, then we will get a larger impact. And that's something that we do in the research that I've been involved in. So the more determinants we can address simultaneously, obviously the higher the impact, albeit the more complex it is and the harder it is to measure sometimes. But it also comes down to, it's all very well having these kind of policies and processes in place, but we do need to actually measure, evaluate, and make sure that these things are actually implemented as they should have been. So I just wanted to share some other data that we've done on children, and this is using data from the Children's Lifestyle and School Performance Study, again, Nova Scotia data, but has relevance elsewhere across the country, where we have a mandated school food and nutrition policy in our classrooms in Nova Scotia. And what you see on this particular graph is that, really we should be seeing 100% implementation of the healthy eating practices that are associated with that policy. Because if a policy is actually going to work, it has to be implemented at the full dose required. But you can see from this, there's quite a lot of spread. And that's because, we can do some things. So things that schools found easy to do was to follow food safety practices. That's things like encouraging people to wash their hands, and we took pop machines out of the classrooms as well. So serving healthy beverages, that was an easy fix, if you like. Harder for people to do is things like competitive pricing or priority space for healthy food. So that's some of the environmental change that gets harder to do. Using local food products, that's really hard to do. And this also applies within the paediatric health care setting as well, I think, in terms of, if you want to have healthy eating policies within your own institutions, these are some of the challenges that you're going to have in terms of actually sort of, setting that up. Really hard, and again, we've just seen examples of that, using only healthy fundraisers and involving students in menu planning. I think that's really odd because really, kids should be learning about healthy foods within school systems, and what better way of doing that than actually involving them in menu planning, but it wasn't happening in our data, which was collected in 2011. And similarly with physical activity. Now, physical activity practices were not mandated at the time that we were doing the study, and still aren't actually. But again, you can still see that sort of similar kind of spread. So some things are easy to do. Phys ed curriculum, participating in some of the sort of like the one-off things that happen in schools, like the Terry Fox Run, but harder to do with things like having the right equipment for physical activity or encouraging active transportation. Doing some of the non-traditional and non-competitive activities was harder. And equally, things like active transportation policy and incorporating physical activity in the classroom. So the harder things get, the harder they are to implement. And so, we need to make sure that any of these things that we're doing also are able to be implemented, that the resources are available to make sure that implementation happens. So, in summary, we're really looking at key ingredients here in terms of actually sort of taking a socio-ecological approach. So this is what I would use as a socio-ecological approach, where we have the individual, the people that they spend their time with, the places that they go, organisational, could be schools, it could be a community health centre, that kind of thing, the community where they live, and then these public policies. And when we're talking about addressing the challenges that we have with weight bias and stigma, we really need to be looking at it across these different levels. And so that needs willingness to change on the part of the individual and their families. We need community buy-ins. Everybody sees this as something that's worth doing, and that the health of children is worth protecting. We need to create those supportive environments so that we're not swimming against the tide and trying to be healthy when everything in our environment is pointing to unhealthy behaviours. We need leadership and political will, and we need those societal norms that support health and that don't actually exist fully at the moment. So to summarise and bring it back to that the whole point of the topic of weight bias and stigma, we must stop assuming that a person's weight is a direct reflection of their health status, because we're all exposed to that environment that is unhealthy. We need to stop defaulting to weight as a measure of health. We often sort of see, okay, the weight on the scales is a measure of health, but actually, somebody can be of a normal body weight and not healthy. So really trying to take away that as a metric. And we need to stop ignoring the multiple factors that prevent us all from achieving our optimal health and well-being. And we need to start or continue to raise awareness about the complexity of obesity. I think that's really important to sort of recognise it's not a simple thing. It's not just about personal responsibility. We need to question personal assumptions about body size and shape, emphasising health and quality of life instead of weight, and advocate for and support systems level change, and really trying to get to that point of supportive environments and policies. And so I'm just going to change my candy cane house, my unhealthy house, to one that sort of is more of a healthy environment of, sort of healthy foods available. And just to sort of like give a little kind of hat tip to the work of Carl Warner, I use a lot of his pictures in my slides, because they're all made out of food. And so if you look at that closely, you can see that that's actually made. There's little bits of pasta, there's almonds, and cherry tomatoes in that picture, and they're very, very cool pictures. So what really matters for child health outcomes? And then here I'm going to sort of just use a quote from colleagues of mine who were based in Newfoundland at the Janeway Centre, Tracy Bridger and Anne Wareham. And say, I think this really speaks to what we need to be doing moving forward. There's been so much attention focused on increasing obesity rates that it's easy to lose sight of what really matters. To refocus, an essential question must first be asked: what do we want for our children? A happy, healthy childhood and continued positive mental and physical health in adulthood is a goal most would have. And just to say that if we want to address obesity and weight bias, then we need to do it by actually taking weight out of the equation and moving beyond BMI. Thank you for your attention. Hopefully, if there's any time for any questions, I think I'd be more than happy to take some now if there's enough time.
All right. Thank you very much. Great presentation. I mean, really a different spin on the whole obesity issue than we've had in the past. I mean, it's a lot of common issues, that whole, working across sectors and engaging communities and the public policy and all of that sort of thing is all so important. It's not just about the healthcare system, but there's certainly a different spin than we've seen before. So thank you very much for that. We do have some questions. So just a reminder to the audience, type questions into the question box, and we do have about 8 minutes or so of official time to try and get through some questions. The first one came in from Amanda. She says, I work at the National Eating Disorder Information Center, and they do presentations for kids about body image and self-esteem. Yeah. She says, how can we ensure that messages about, in quotes, health don't lead to guilt and obsession when it comes to food and weight? Their research shows that kids as young as grade 3 are starting to diet.
Yeah. That's a really, really great question and a very important question. And it's one I get asked a lot as well. And I think this actually comes to where, we need to be thinking about the modelling that we give around healthy behaviours, because we don't want to be causing other problems, and I think that's there's unintended consequences. The best intentions, often we do things, but we want to be very careful and mindful of those unintended consequences. And I think that's where it really comes to sort of saying, okay, presenting things as healthy needs to be done in a way that's like, this is good for everybody. It's not not just focusing on it's good for weight loss, because actually it's probably not, as we've, as I've explained. So we really need to be thinking about, health behaviours as positive behaviours, rather than things that are perhaps seen to be negative or punitive, or having that sort of negative connotations. And I think this is where I'm also very keen to sort of see us really thinking about physical and mental health going hand in hand. I worry a little bit that we focus on one or the other and not both, and really thinking about positive mental health. Being active is really important. Actually, it really we think better better when we're active. We think better when we eat better. And that helps our brains, and it also helps our bodies. And I think if we took away some of that negativity around the way that health messages have been framed, we'll get to that point. But it's going to take a concerted effort and leadership from many of us to do that, so that we don't then have that kind of, those negative sort of connotations coming out. I hope that's answered that question. It is a very, very important question.
And I'm sure it did answer her question. That was a great response. And she said, Amanda just commented, yes, it did answer her question. So
thank you.
Jennifer's asking, what's your opinion on a sugar tax?
Oh, there's another question I get asked a lot these days as well. I would say it's complex. I always feel like I hide behind that, but it's not really hiding. It's so we've actually been looking into this we haven't kind of written anything yet, but I think we have to be so careful with how we frame messaging around things like sugar taxes. If it's sugar sweetened beverages, we could argue that nobody really needs them. They're not a kind of core component of our diet, but it becomes a lot more complex when we start thinking about it in other foods. And I think we don't want to demonize one food over another, because that's not healthy either. I mean, healthy is being able to have things in moderation. But I do also think that the evidence that's coming from other countries is actually that it's working in terms of reducing consumption patterns. But it also means we have to have alternatives. And so, I would argue that having water is a great alternative. We don't need sugar water. But we also, need to be thinking, okay, if we are going to go down the road of a sugar tax, we need to be thinking about who's it going to impact positively and who's it going to impact negatively. I showed a slide earlier which showed you the cost of sugar sweetened beverages versus the cost of milk. So we need to be thinking about those kind of issues. So I think it's something that we need to do a lot more kind of careful consideration of as to how it fits within the sort of overall picture. It shouldn't be something that's done without considering both the intended and the unintended consequences, because that, I think, just makes things worse.
All right. Kelly says, shame is certainly not motivating. She agrees with that, but then says, how do we empower patients to lose weight given how little their own behavior influences their weight? Or do you not advocate weight loss if patients are otherwise healthy?
Yeah. So I think there's two different things going on there. First of all, we can change our behavior, but we cannot change our weight as much as we think that we can. That's not to say that if our behavior is changed and sustained that we can't see weight loss. So I think it's a complex message, and it's a complex thing to sort of try and explain, and even in just an hour presentation, it's hard to sort of convey all those things. But we can change behavior, and so what we need to be doing is, okay, maybe weight loss is not the goal that you should have, but maybe feeling better about yourself, having a better quality of life, being able to walk without getting breathless. So actually sort of looking at more health-related outcomes and weight-related outcomes should be the goal. That is a complete flip around the way that we've been doing things for many, many years, because weight has always been our primary goal in a lot of treatment options. If we're just thinking about it more from a health behaviours, and I think also the other thing that's really important is that we engage people more in the conversation. One of the things that came out of our research is the tension that people within the health system who are actually sort of supporting people to lose weight or manage their weight kind of feel that they have nothing to offer. And I would actually argue that that's true. We have a lot more to offer when we look at it in terms of behaviours. It's a lot easier to kind of help people to meet those behaviour goals than it is to meet a sort of fairly sort of abstract goal. That often people's weight related goals are nowhere near where they've ever been in their entire life, so they're all unachievable anyway. So I think if we just need to sort of try and, I would say it's far more complex than that, but trying to reframe it so that the behaviour is what we're focusing on, not the weight, and that the measures that we're looking at are behaviour measures, not weight related measures.
All right. Lisa's asking, what is the balance of evidence about the use of behavior modification devices like Fitbits and iPhone apps or various mobile apps that measure physical activity, screen time, particularly for children and youth? Is there evidence just specifically?
There's not a great deal of evidence in children and youth, to be honest, as far as I'm aware. Now, certainly the evidence for adults was quite mixed the last time I looked. And again, it also depends on what you're looking at it for. In terms of weight loss, then they don't seem to have a great role so far. In terms of behaviour change, they might. And so I think, again, it's sort of like looking at, often we're looking for an outcome that is not fit for purpose in terms of the mode, if you like, of delivery. So certainly I wear a Fitbit. I mean, I'm a sample size of one, and I find it very motivating. Other people maybe won't. So I think, again, you need to sort of work with people, find out a little bit more about what would be motivating for them or not, because again, you don't want to be increasing guilt or making people become a slave to the technology. Certainly in terms of things like apps, there is some evidence that they are helpful, but again, it depends on, there's a lot of complexity then in terms of how they're constructed and how they're used as well. So, I think it's a very fast evolving field as well. Obviously, technology is something that's really sort of moving fast, and actually the research hasn't kept up with the technology, so we have more technology and less robust research at the moment.
All right, so I think we have time for maybe one or two more questions here. The next question is from Juliet. She says, a very interesting talk that will change the discussions she has at her clinics. Do you have any experience with MEND, M-E-N-D? It's a form of weight loss.
I do. Yeah.
Now, MEND stands for Mind, Exercise, Nutrition, Do It. I just want to get an opinion on that program.
Yeah, no, I actually, the person who sort of originally set up MEND is from the UK, and I actually was familiar with it when I was working in the UK, which is sort of like over 10 years ago now. So it's a fairly well-established program, and I know it's been used across the country. I think, again, from what I understand, I haven't reviewed the evidence specifically on this for a while, but the last I looked, it had some good outcomes. And the thing I like about it is that it's focusing on mind and body, and I think that's very important to be sort of looking at both of those things. It's one program of several that I'm aware of. Again, I think if people are interested in it, certainly do their research about the outcomes more recently than I have in my head, but very much it's another approach to be taken, and it follows that philosophy, I think, around removing some of the emphasis on weight, which I think is really important, but not something that we have been doing routinely so far.
Right. Jennifer's asking, do you feel, we've heard that, I think I've heard this lots of times, the whole issue of larger bodies also being healthy, such as a yoga instructor or a dance instructor that's overweight or obese?
Yeah. Again, the evidence is mixed on this. There was something quite recently came out saying that, it's a myth that you can be fit and fat. And that's how they say it, not how I would necessarily say it. So sort of people being of high body weight, that's okay. But that was, again, epidemiological research, and we already know that there's challenges with that. So, I think we need to be much more sophisticated in our measures of what we mean by that, but I do think that again, if we're taking the emphasis away from weight as our outcome and thinking about behaviours, people are meeting are being active, that's going to be beneficial regardless of whether their weight is higher. And I think it's really great to see more of this being modelled as well, and I think the other thing that I think is really fantastic is the Public Engagement Committee of the Canadian Obesity Network now. So they're actually engaging people of high body weights in their planning, and I think that's what we all should be doing. This is something that nothing about us without us. We really need to be engaged engaging our stakeholders in coming up with the messaging that we're using, and that's something that we're doing a lot more in the work that we're doing. I do a lot of work with the Canadian Obesity Network around the weight bias area, and that's something that we've been really focusing on, is actually sort of coming up with messaging alongside the people who are experiencing challenges with their weight.
We'll take one more question before we sign off. Julie is asking, since you were aware of the program in Saskatchewan, she's now got a question about a program in BC. She says, are you aware of the Balanced View resource that was developed by the Provincial Health Services Authority in BC?
I am, and I would actually recommend that as a great resource. It's very well put together, very well researched. Again, I've spoken to the people who put that together, and they very much share the same kind of philosophy, I think, around, again, it's that balance. We're trying to sort of achieve a balance, and I think what I also like about that is that it's again giving voice to people, so that the messaging is very much framed around sort of addressing some of those tensions that we inevitably feel and see within within this sort of this realm. The earlier question around sort of like the unintended consequences and the possibility of increasing eating disorders. The people who put together the Balanced View, I believe, work more, or certainly were sort of from the eating disorder field, so they're bringing sort of that lens to it, which I think is really important. And actually, my earlier career was actually in eating disorders as well. So I kind of often sort of felt that I was sort of sitting on the fence a little bit in terms of, having worked with eating disorders and sort of worked with people with obesity, and sort of seeing commonalities across both approaches, that we needed to sort of, change the way that we do things to reflect that. So yeah, great resource.
All right, and Julie, if you have a URL for that resource, if you just send that to us, we can maybe quickly put it in the chat box to share with the rest of the audience for anyone else who might be interested in it.
Yeah, I can probably find that as well if Julie can't. And also, if anybody's interested in any of my papers, just let me know, and I can also send those through to the office as well.
Yeah, and if you want to send those to us anyways, Sarah,
sure.
we can put those on the Knowledge Exchange Network. Any links to any of those, or the documents themselves, whichever you think is easiest. All right, I think we are out of time. Great conversation, great discussion. We're just going to hand it back over to you one last time, and if you have any sort of closing comments, you had that great sort of key ingredients slide, which was a nice nice sort of slide that sort of wrapped everything up. But if there's any other key messages you'd like to leave the audience with before we...
I think, I would say that we're all role models, and we need to be reflecting on our own behaviour and making sure that, that our messages are aligned with the sort of goals of what we want to be doing for our children, our families, and ourselves. Strength-based approaches, to me, are the way forward, and that means being positive with our messaging rather than the negative sort of do not do, which has been in the past. So not quite a sort of a crisp finishing there, because I could talk for hours about this subject, but I really appreciate those great questions and the opportunity to share the work that we've been doing with you as well. So thank you very much.
Once again, lots of great comments in the chat box here. People thanking you and saying how great the presentation was. So thank you very much from all of us. All right, and with that, I think we'll wrap it up. As most of you know, we do our webinars every Wednesday at 11 a.m. Eastern Time, and the conversation that, like the one we just had, is always one of the reasons that people show up. But when you can't show up and participate live in the presentation, we do record these sessions and post them on our Knowledge Exchange Network after the fact, so you are always welcome to go there and catch up on anything that you might have missed today. Next week, on May 31st, we'll be hearing about the Trek Peds Pack, having what you need at the bedside to manage acutely ill children in the emergency department. Peds Packs are best evidence point-of-care resources for managing critically ill or injured children. These tools are intended to be used at the bedside in community and tertiary pediatric emergency departments in Canada, and the available resources consist of both cognitive and instructional aids, and we'll be hearing from Trek co-director Dr. Mona Jabor, who's also from the Children's Hospital of Eastern Ontario in Ottawa, who has led this national multidisciplinary team consisting of emergency physicians, intensivists, pharmacists, nurses, and specialists in various topic fields. And after that, on June 7th, we'll be hearing from Dr. Jonathan Lai from York University and Esther Ree from Autism Speaks Canada, who will be talking about people with autism spectrum disorder and their families, and asking the question, what services do they truly need? And that's going to be a presentation about some research that talks about the services that are available for families and some of the some rate data around what people are actually accessing and whether the services that are available are actually meeting needs. And Esther from Autism Speaks Canada is going to talk about how that impacts families of children with autism spectrum that are on the autism spectrum disorder spectrum. So a great presentation, certainly again a topic of high interest to most of our community out there. So some great stuff coming up in the next few weeks. Thanks again to Dr. Sara Kirk from the IWK and Dalhousie University for joining us today, and we hope to see everyone back here next week. Bye, everyone.